Even though it is easy to use, the pulse oximeter can produce erroneous data in certain circumstances. One common problem is the occurrence of movement artifacts when there is movement at the site where the probe is placed. This may interfere with proper function and most often occurs if a patient is shivering, has seizures, or is being transported by ambulance or helicopter. The waveform of the pulse oximeter will be distorted in such circumstances, and the clinician should recognize that the measurement displayed is inaccurate. A bright light, such as an operating room lamp, may cause light interference, leading to an erroneous reading. Electromagnetic radiation, such as that emitted from an MRI scanner, may also interfere with pulse oximetry. If the probe is poorly placed or is the wrong size, light from only one light-emitting diode may pass through the tissues, or the light may not reach the detectors. This will result in falsely elevated or depressed results. Nail polish that absorbs light at 660 nanometers or 940 nanometers may also interfere with the pulse oximeter and result in an inaccurate reading. This problem can be avoided by removing the nail polish. The presence of intravascular dyes such as methylene blue or indigo carmine may alter the red and infrared light absorption properties of the blood and tissues, also resulting in an inaccurate reading. Non-functional hemoglobin can also result in inaccurate pulse oximeter data. At 940 nanometers, the light absorption of carboxyhemoglobin is minimal and does not affect the SpO2. However, at 660 nanometers, the light absorption of carboxyhemoglobin is similar to that of oxyhemoglobin. The pulse oximeter cannot differentiate between oxyhemoglobin and carboxyhemoglobin in this instance, and may erroneously display a normal or near normal arterial blood oxygen saturation when the actual arterial blood oxygen saturation may be low. At 940 nanometers, methemoglobin absorbs more light than either deoxyhemoglobin or oxyhemoglobin. At 660 nanometers, the light absorption of methemoglobin is similar to that of deoxyhemoglobin. In this instance, the pulse oximeter cannot differentiate between methemoglobin and deoxyhemoglobin and may incorrectly detect an elevated deoxyhemoglobin concentration, resulting in a falsely low interpretation of arterial blood oxygen saturation. Carboxyhemoglobin may cause a falsely high SpO2, whereas methemoglobin may cause a falsely high or falsely low reading, depending on the actual concentration of oxyhemoglobin. Newer pulse oximeters are able to emit light at up to 8 different wavelengths. This increase in the number of available wavelengths makes it possible for the oximeter to distinguish carboxyhemoglobin and methemoglobin. There are additional limitations. Peripheral vasoconstriction, hypoperfusion, hypothermia, shock, and anemia may also yield inaccurate results.